Eklhatib is a board-certified gastroenterologist with additional advanced training in therapeutic and interventional endoscopy. He received his internal medicine training at Northwestern University in Chicago and went on to complete his fellowship and sub-fellowship training at the University of California, San Diego, under the mentorship of one of the nation's experts in endoscopic ultrasounds. He has a special focus on pancreatic biliary diseases, including pancreatic and bile duct cancers, pancreatitis, and as well as GI oncology. With expertise in advanced biliary endoscopy and endoscopic ultrasounds, and in addition to numerous endoscopic techniques, he has been serving the Southwest community of the Chicagoland area for over 7 years now. Please join me in welcoming Dr. Eklhatib.
Thanks, Nicole. Hi, everybody, and thank you so much for having me here. I hope technologically everything goes well here. In this new era that we're in of Zoom meetings and telehealth and all that, it's been a learning curve for everybody here. So hopefully this goes relatively smooth. Like Nicole said, I'm a therapeutic gastroenterologist. I've been in practice here in the Southwest community of Chicago for about almost going on 7 years now. And I have a very special focus on pancreatic biliary diseases. So pancreatic cancer in particular is one of my focuses. And we were just talking kind of before logging on. This is something that affects all of us. Pancreatic cancer is a condition, a disease, a pathology that's not only increasing in incidence, but is also relatively stagnant in terms of some of our advances over the past years. And for anybody who knows, anybody who's had pancreatic cancer, or anybody who is a survivor of pancreatic cancer, or anybody who's going through pancreatic cancer right now, we can all know that this is a very devastating cancer to have on multiple fronts. It's a complicated organ with multiple functions and tends to really affect us on multiple fronts. And so, this is something that I think is important for all of us. My hope today is just to kind of go over a little bit of pancreatic cancer, some of the diagnostic testing that's available for pancreatic cancer, some of the signs and symptoms of pancreatic cancer, as well as some of the risk factors. We'll do a little brief review on sort of the management, and then we can talk about how do we help deal with some of the complications of pancreatic cancer. Aside from the treatment of the underlying disease itself, the goal would be to talk about how we can deal with some of the really debilitating and problematic symptoms patients with pancreatic cancer can deal with. So my hope is that this would be relevant to anybody with pancreatic cancer or any family history or family members with it. So I'll kind of go through here. And again, somebody flag me if there's any technologic issues here. So pancreatic cancer, a little bit of sobering statistics here. This is a cancer that is relatively common. It is increasing in frequency. And if you look at the American Cancer Society statistics, in the year 2021, it's estimated that about 60,000 Americans will be diagnosed with pancreatic cancer. And of those, 48,000 Americans will die of pancreatic cancer. As of 2016, pancreatic cancer surpassed breast cancer to become the third leading cancer-related death in the US. And it's felt to, over the next couple of years, potentially increase to become the second leading cancer-related death in the US. 71% of patients diagnosed with pancreatic cancer tend to die within the first year. And it's those numbers, it's that number in particular, that we are working our hardest to change, okay? And we'll talk about some of the obstacles that we face when dealing with pancreatic cancer and why this mortality rate the first year is so high. And, kind of going along the same lines, pancreatic cancer is the only major cancer with 5-year survival rates in the single digits. And so let's go into this a little bit more here. Okay, so if we look at sort of the percentage of patients who are diagnosed with pancreatic cancer, if we look at here on this slide over here, this is detecting or depicting the stage that patients tend to get diagnosed. So meaning this is when patients first get diagnosed, find out that they have pancreatic cancer, what stage are they and how advanced is their cancer? And if you can see here in this pie chart over here, only about 11% of patients who are diagnosed with pancreatic cancer have what's called localized disease, meaning that their cancer is early and localized and can maintain just in the pancreas. Whereas an additional here, if you look at this sort of darker spread here, and this is the more important one, this distant here, we're looking at over 70% of our patients plus are diagnosed with pancreatic cancer at a stage where the cancer has already spread to distant sites. And that definitely can limit some of our therapeutic options there. Okay. All right, so, sorry, I'm just trying to move this little thing on the side here. Okay, so why is this important, this whole diagnosis by stage and how advanced the pancreatic cancer is when we diagnose them? Well, as you know, with any cancer, the survival and how patients do is directly dependent on the stage of the cancer. And when it comes to pancreatic cancer, this is part of some of that sobering statistics we were talking about earlier, the more localized the disease, the higher the likelihood of cure and the longer the survival. And so with localized disease, you know, there's a 5-year survival of about 41%, whereas patients who already have distant or metastatic disease or stage 4 disease, their 5-year survival is around 3%. So this is where it's important, you know, to note that a lot of these patients that are being diagnosed with pancreatic cancer are being diagnosed at an advanced stage. And that's part of what's driving some of the very high mortality and these sort of ugly numbers, is that we're picking this up late. And what we'll talk about a little bit later is what are some potential risk factors that may help us to try and pick up some of these patients at an earlier stage. So just a review of the anatomy, okay? So the pancreas is actually in a very busy area of the abdomen. So the pancreas itself is a non-encapsulated organ. So essentially that means that the pancreas does not have a capsule around it. This is a digestive organ. And so this is an organ responsible for digestion as well as metabolism, as well as the production of insulin, as well as other enzymes that are responsible for breaking down some of our nutrients. And if you look at just sort of some of the structures that are around the pancreas, you can see here that it's very intimately involved with a couple of things. At the tail end of the pancreas, you have the spleen, as well as some of the major vessels coming out of the spleen. You have the left kidney, which is sort of behind the pancreas tail and body. And then as we go towards the head of the pancreas, we see that this is very closely involved with the very first portion of our small bowel called the duodenum. And if it's not shown in this picture here, but there is your stomach would be right in front of all of this. So the pancreas is what we call a retroperitoneal organ, and it is very closely involved with a lot of these structures. Blood vessels tend to course throughout and very near to the uncinate process and head of the pancreas. So it's packed in a very, very busy area. The reason for this slide is just to again depict that the pancreas actually, if you think about it, it's a little bit closer to your back. It's a very deep organ. And so a lot of times when patients talk about pancreas type pain, a lot of times you'll hear them refer to the pain actually going towards their back rather than up front. And again, some of this just has to do with just the location of this organ being sort of a retroperitoneal or a deep abdominal organ. One important anatomic structure here is something called the bile duct. The bile duct is a vessel, or I'm sorry, a duct that transfers bile from the liver into the gallbladder, and it passes through the head of the pancreas into the small intestine, where it empties out through this little opening called the papilla, where that bile mixes with your food. I'm bringing this up because, as we'll see later on, some of the complications of pancreatic cancer are related to involvement of these important structures that are so intimately involved with the pancreas. The pancreas also has a very abundant vascular flow. So the vascular supply to the pancreas is very robust, and this also perhaps plays a role in the early metastasis that occurs with pancreatic cancer, and why pancreatic cancer may spread to distant sites at a relatively earlier stage as opposed to some other cancers. The pancreas, for anybody that knows someone who's had pancreas issues, either pancreatitis or pancreatic cancer, this is very painful. Some of this pain is unlike anything anyone's ever felt before. And part of the reason for the pain that can come from pancreas diseases is that there's a nerve plexus, which is very close to the pancreas, sort of just right behind it. And that's called the celiac axis ganglion. And this is a ganglion that is a splanchnic nerve center and is responsible for transmitting some of the pain of the foregut, so the upper abdominal structures, to the central nervous system. And it is very, very close to the pancreas and is very commonly involved. So kind of shifting from the structure of the pancreas to the function, again, this is a digestive organ. It has two sort of categories of function. There's the endocrine function, and when we say endocrine, that refers to the secretion of hormones. One of the most important ones that we know of and talk about is insulin. And insulin is produced by the beta cells in the head of the pancreas, and is very important in our glucose metabolism. And so that's why we talk about the development of diabetes sometimes in patients who have problems with their pancreas, including pancreatic cancer, is because of disruption of some of these important cells. The other main category is exocrine. Exocrine refers to the release of enzymes, and there's several enzymes that the pancreas releases through this pancreatic duct, which then enters into the small bowel and mixes with your food to help you digest. We have amylase, for example, that helps break down, starch. We have, lipase, which is important for our fat metabolism, and certain proteases, which help us break down protein. So these are all very important enzymes to help in metabolizing some of the main fundamental components of the things that we eat to help us gain nutrients. Understanding these helps us understand, like we'll talk about a little bit later, why people sometimes develop pretty significant weight loss when there's problems with the pancreas. Okay, so let's kind of now talk a little bit about the symptoms of pancreatic cancer. So I'll start by saying that sometimes there are essentially no symptoms in pancreatic cancer, and the symptoms really don't develop until things are a little bit advanced. So not everybody who has pancreatic cancer is going to have symptoms initially, and not everybody with pancreatic cancer may have the same symptoms, but a lot of the symptoms have to do with some of the function impairment that occurs in the pancreas, as well as involvement of some of the adjacent organs that we just sort of talked about. But the thing you'll hear about the most is jaundice. So if you develop yellowing of the skin or eyes, and this is a sort of a symptom that, if anyone ever develops it, it always warrants attention by a physician. There's many different causes of jaundice, but when we're talking about pancreatic cancer, jaundice is one of the hallmark symptoms, or among the more common symptoms to see. Dark urine. Dark urine occurs because the same process as why the jaundice occurs, and that's because of disruption of the bile flow. And we'll show you a little bit diagram of that here in just a second. But this disruption of bile flow because of blockage of that bile duct results in a couple of physiologic changes: the jaundice, the dark urine. Sometimes people will also say that their stool has turned color to a clay, like a sort of a clay colored or a tan or a lighter colored stool. Those are all because of aberrations in the bile flow and metabolism. Upper abdominal pain. As we talked about, this can be very painful, and a lot of times people will describe the pain radiating towards their upper back. Weight loss. Weight loss can be pronounced and usually does signify a more advanced disease. Oily stools, that has a medical term, which is steatorrhea, and that essentially refers to stool that is very oily, very foul smelling, and very fatty. And that is a product of the inability to break down fats. And so we have more fats that make it down into the colon, and that causes our stool to be oily. And we'll talk about that in just a little bit. New onset diabetes. This is something that's also very important, where patients sort of out of the blue develop diabetes, and that could also be a sign of pancreatic cancer. But again, aside from maybe the jaundice, the other symptoms usually indicate or are more present in late disease. So jaundice, again, occurs because if you look at this diagram here with the pancreas, you have the first portion of the small bowel, and you have this green structure, the bile duct. The gallbladder is over here. Your liver makes this bile, which passes down through this bile duct, which empties out through a tiny opening in the first part of the, or second part of the duodenum. When there's a process involving the head of the pancreas, it can block this bile duct, and the bile has nowhere to go. And so that bile sort of builds up, spills into the bloodstream, into extracellular locations, and people can manifest discoloration. And the most common area to see it first, or the earliest area, is going to be underneath your tongue or in the whites of your eyes. This is just an example of some skin changes that you can see with jaundice. So this is a picture of steatorrhea. Hopefully you guys had your dinner already, but you can't have a GI talk without at least one picture of stool, right? It's just, you have to. So this is what steatorrhea would look like. And most people will describe sort of seeing these oil droplets. The stool tends to float. It tends to be very foul smelling, have a yellowish hue to it. And again, the presence of oil droplets is the most telling sign that there's fat in the stool, and that, this is something that needs to be addressed. So with the symptoms in mind, and a patient is being evaluated, how do we diagnose pancreatic cancer? How do we come to the conclusion that someone has pancreatic cancer? Well, there's a couple of tests that we use. The most common by far and away is going to be some form of cross-sectional imaging, like a CT scan of the abdomen with contrast. And that's what you see over here on this side. That's probably the most useful and the most commonly used test for picking up pancreatic cancer. Now, the problem with pancreatic cancer is when it comes to imaging of the pancreas, these tests are not 100%, including CT scans. There are limitations, and pancreatic cancer can sometimes be an infiltrating process where instead of just forming a lump or a growth like we're sort of very used to thinking about when we think of tumors, sometimes pancreatic cancer can be more of a infiltrative process that causes more of a desmoplastic reaction where it's sort of very poorly defined, and sometimes that can be missed on scans. Scans can also sort of miss sometimes some smaller tumors. And in the pancreas, which is a very busy organ, it's very common that sometimes CAT scans can miss tumors. MRIs can give us additional information at a little bit higher sensitivity. But probably the most sensitive and most accurate test is something called an endoscopic ultrasound. And that is a scope with an ultrasound probe on the tip of it that goes down into the stomach and then is thus only a few millimeters away, allowing us to get very good views of the pancreas. So one of these tests is going to be utilized. Usually it starts with a CT scan. They see something that looks concerning for a possible growth or process in the pancreas, and that's followed up with maybe some blood work. there's a tumor marker called a CA19-9, which tends to be elevated, but not always, in patients with pancreatic cancer. If you have a mass in the pancreas and you have a CA19-9 that's elevated, that is pretty incriminating for pancreatic cancer. But like most cancers, tissue is the issue, and a true diagnosis is oftentimes only sealed with a biopsy. And that biopsy is oftentimes obtained with an endoscopic ultrasound, or sometimes in certain locations with a CT. Sometimes these are also just diagnosed during an operation where they take out or do a sample at the time of a surgery. But those are some of the main tests that we look at. The endoscopic ultrasound, for anybody with any pancreatic condition, they'll be very familiar with this because this has become sort of the gold standard for pancreatic evaluation. And what we do is, under sedation, we advance a scope, as you can see on the screen here, that has both a camera, which allows us to see inside the stomach, just like a traditional endoscopy, but there's also an ultrasound probe on the tip of it. And because we're only a few millimeters away from the pancreas when we're down in the intestine, we get phenomenal views, better than a CT, better than an MRI. And more importantly, we have dynamic ability to move our probe. We can look for exactly what we're interested in seeing rather than relying on a static image that is obtained with certain other cross-sectional imaging. So it's a very, very useful test. And the other advantage of the endoscopic ultrasound is, while we're down there taking a look and seeing what's going on, we can take biopsies, and that's called a fine needle aspiration. Okay, so this is an example of what an endoscopic ultrasound image would look like for somebody with pancreatic cancer. This is our probe here, and I know this may just look like sort of static here, but this is what we'd be looking at in real time. And we can see here this sort of darker area as opposed to the remainder of the pancreas. That's the tumor in the pancreas. And what we're doing here is, under direct visualization, under real time, passing our needle in and out of this tumor, and we are acquiring tissue that way. And this is all done painlessly under sedation, and can be done in as quick as 15 minutes. We take that tissue and we put it in a little specimen and we send it to our pathologist, and they look at it under the microscope and they tell us if we got enough cells, and they tell us if we are positive for cancer or negative for cancer. The yield of this is quite high. It's very specific. If you have a positive test at the time of an endoscopic ultrasound showing pancreatic cancer, usually means you got the right diagnosis. Now, sometimes these aren't 100%. Sometimes we'll get what's called a false negative, where we take a biopsy and it comes back negative for cancer, but it actually still is cancer. And that's a sort of one of the downfalls with biopsy of any cancer. And that's because sometimes when you have a growth and we're taking a very thin needle and we're sampling sort of just a small part of this full structure, sometimes the cancer cells may not be in that specific site that we ended up sampling, but there's still cancer there. So we always tell our patients that false negatives are still possible. This is just kind of going over that, using an endoscopic ultrasound or a CT. They're both very accurate, but the endoscopic ultrasound is better for smaller lesions and is got a decreased risk. So we've done the diagnostic tests and we've diagnosed pancreatic cancer. And the next most important question, and the question that's on most patients' mind, is, well, what's the stage? And staging of pancreatic cancer goes by the American Joint Committee on Cancer, the TNM classification. T stands for the extent of tumor, N is nodes, M is metastasis. So you'll see this with many cancers, GI cancers among others. And for pancreas cancer, the T essentially refers to the size of the tumor and well as the involvement of adjacent structures. So a T1 tumor is less than 2 centimeters. A T2 tumor is between 2 and 4 centimeters. A T3 tumor is greater than 4 centimeters. T4 usually involves growth out of the pancreas involving adjacent structures. The lymph nodes, or N, go by N0, meaning no lymph nodes, N1, 1 to 3 lymph nodes, N2 is greater than 4 lymph nodes. M stands for metastatic spread. And so we assign numbers to this T&M classification that helps determine the stage 1, stage 2, stage 3, or stage 4. And there's little subgroups between each, some of the earlier stages as well. But that's sort of the gist of it. And why do we care about stage? Well, stage directly correlates to the survival, and stage dictates how we will treat. So in practice, we refer to maybe 3 sort of major groups of staging. We talk about a cancer that's resectable, we talk about a cancer that's borderline resectable, or we talk about a cancer that's unresectable. Those are the practical stages. And essentially, a cancer that is resectable refers to a cancer that is localized within the pancreas and can be treated by removing it surgically under curative intent. So we consider our resectable pancreatic cancers, which are early stage, something that we can potentially cure. A borderline resectable would essentially involve a tumor that's perhaps involving some of the adjacent vessels to a certain degree, getting close to a vessel, or is a size that is quite burdensome and may not be something that can be removed surgically up front, but still has a possibility to be removed surgically with curative intent after it's shrunk using what's called neoadjuvant therapy, which means either chemo or radiation prior to a surgery, and then seeing if it worked and shrunk things, and then going in for surgery. So that's what's called borderline resectable. And then unresectable usually refers to advanced stage or stage 4, or cancers that have spread, beyond the pancreas. And when we reach this point, we don't have any effective cures at this point, or our therapies are not under curative intent, but more geared towards palliation and improving the quality of life and the symptoms involved with the pancreas, rather than going for cure. So that's the staging sort of mentality and thought process. That staging is done in combination with the CT as well as the endoscopic ultrasound, like we talked about earlier. We can see the vessels and its involvement with the growth. We can look for lymph nodes. We can biopsy them if need be. So the EUS is essential in pancreatic cancer for a variety of reasons. The curative surgeries for pancreatic cancer are usually of 2 sort of main types. The type of surgery on the pancreas depends on where the tumor is. So for a tumor that's in the head of the pancreas, oftentimes you'll hear what's called a Whipple procedure or a Whipple surgery. And this is a surgery in which the head of the pancreas is removed. But because the head of the pancreas is in such a busy area with the bile duct going through it, as well as this wrapping of the first portion of the duodenum, you end up having to do more than just cutting out the head of the pancreas. You have to cut out the head of the pancreas. You have to cut the bile duct, above where it enters the pancreas. You have to get rid of the first part of or move the first part of the duodenum where it is involved with the pancreas, and sort of reattach everything. So it's called a pancreaticoduodenectomy or a Whipple procedure. And it's quite a large surgery. And we've come a long way throughout the years in terms of improving our outcomes with this. And so surgeons, especially pancreaticobiliary surgeons, are getting very good. And the higher number of surgeries or Whipples that a pancreaticobiliary surgeon performs, the better they are at it. And this is a surgery that definitely needs to be done only in expert hands. When we talk about a tumor that's in the tail of the pancreas, that may not require a Whipple procedure. The tail of the pancreas is a little bit less busy, and so the surgery is a little bit less intricate, but still, considered a major surgery, and that's by cutting out the tail end of the pancreas. A lot of times, they will also take out the spleen and do what's called the splenectomy, and that's a distal pancreatectomy. Now, there are variations of these surgeries. You can have what's called the subtotal pancreatectomy, where they take out, the majority of the pancreas aside for a small amount, or extended distal pancreatectomy. But for all intents and purposes, those are sort of the 2 main, categories. Are we taking out the head, or are we taking out the, the body or tail? Chemotherapy is, when it comes to pancreatic cancer, as well as other cancers, is usually described as either what's called neoadjuvant or adjuvant. And the terminology just refers to when we're giving the therapy. Neoadjuvant is chemo and or radiation given prior to surgery, whereas adjuvant is chemo, radiation given after surgery. All patients who undergo surgery for pancreatic cancer will require adjuvant. It's not like, say, some colon cancers, which tend to be early. You may, not need chemo or radiation afterwards. When it comes to pancreatic cancer, chemotherapy will always play a role, even in curative intent. And neoadjuvant, again, is the intent is given to shrink the tumor, debulk the tumor, get an idea of what the tumor biology is, see how it responds, and then, give surgery if things look a lot cleaner or better. Okay, so, what about risk factors for pancreatic cancer? With all cancers, we're always on the quest to try and figure out how we can pick up who's at highest risk of a cancer. Because again, as with any cancer, the earlier we are at picking up a cancer, the higher the likelihood we are to cure this, and the easier it is to cure it. So with pancreatic cancer, there is great interest to figure out what are the subset of patients that are at the highest likelihood to get pancreatic cancer. And that way we can focus on those people and offer them screening tests. And screening tests are tests that are given to a patient before they develop any symptoms, sort of asymptomatic patients who are at risk for a condition that's prevalent in the environment or in the society, with the goal of picking it up early. And with pancreatic cancer, we don't have as good data or risk factors as we do for some other cancers, but we're going to talk about sort of the main ones that we have. First, there's environmental. The biggest by far and away risk factor that's very well established is smoking. Smoking increases your risk of pancreatic cancer by almost, more than tenfold. So that is one of the biggest risk factors. Smoking has a lot of other, tumor-related risk factors, but the pancreas in particular, it is a very high risk factor, and it's a modifiable risk factor. Obesity, specifically BMI greater than 30, also imparts a higher risk of pancreatic cancer, more than 2 times those who are not obese. There's a slight increase in pancreatic cancer in males. As we get older, pancreatic cancer has a higher incidence. Pancreatic cancer is more common in African Americans than in Caucasians, albeit with just a slight increment. Chronic pancreatitis, which refers to chronic scar tissue from inflammation in the pancreas, is a very important risk factor for pancreatic cancer. Alcohol consumption is one of the most major causes of chronic pancreatitis due to the damage of the pancreas. When a patient develops chronic pancreatitis, scar tissue develops in the pancreas, and because of that higher turnover and some of the previous inflammatory insults, they are at significantly higher risk of developing pancreatic cancer. Now, not all patients with chronic pancreatitis will go on to develop pancreatic cancer, and we still don't know what exactly that increased risk is and what subset of patients with chronic pancreatitis are at highest risks. But we're not screening everybody with chronic pancreatitis for pancreatic cancer, but we do have a very high index of suspicion for looking for pancreatic cancer in someone who has chronic pancreatitis that develops a new symptom. Now, the family history part, I think, is very important. This is sort of the genetic part of pancreatic cancer. The majority of pancreatic cancers are what we call sporadic, meaning they occur for the first time in somebody who does not have a family history of pancreatic cancer. But there are a good portion, maybe 20 to 30%, that are genetic or are hereditary. And these are patients that have a potential genetic mutation or have a familial trait in which this is passed down. And so if you have a family member, especially a first-degree family member with pancreatic cancer, you are at elevated risk for pancreatic cancer yourself. The number of relatives that you have directly increases that risk. So if you have 2 first-degree family members with pancreatic cancer, you have a very high risk of pancreatic cancer yourself. 3, you have an exceptionally high risk. And as we'll show on the next slide here, or the slide after that, these are the patients that we are trying to identify because these are patients that qualify for pancreatic screening or pancreatic cancer screening. Inherited syndromes, and I think this is important too. Now, this isn't very common, but these are risk factors for pancreatic cancer that we have established that can really help us enroll for screening for pancreatic cancer. So there are certain mutations in certain genes that can increase your risk. Some of these genes you may be familiar with because they have overlap with other cancers. An example would be the BRCA1 or BRCA2 genes. Okay, these are more commonly associated with breast cancer or ovarian cancer, but they also increase the risk of pancreatic cancer. There is a form of hereditary breast cancer, which is caused by mutation in the PALB2 gene. There is additional mutations in P16 in certain, but albeit much more rare, genetic conditions associated with skin and eye melanomas. People who have a family history of what's called familial pancreatitis. And this is a genetically inherited cause for chronic pancreatitis. They have lots of family members who have pancreatitis because of this, and they have a mutation in the PRSS1 gene. Those patients have a 40-fold increased risk of developing pancreatic cancer. Lynch syndrome, which is also known as hereditary non-polyposis colorectal cancer syndrome, which is more commonly associated with colon cancer, can also be associated with a slight increased risk of pancreatic cancer. And then finally, something called Peutz-Jeghers syndrome, which is a genetic mutation in the STK11 gene. So people who have these genetic mutations, it's very important that they have a sit down with the geneticist and with their doctor and talk about screening for pancreatic cancer, as well as potentially screening their family members. And the way that we approach this is based on, data from something called the CAPS Consortium, which essentially has sat down. It's a panel of experts across the country and the world that have sat down and just looked at what's the best way to approach patients who have risk factors for pancreatic cancer screening. So right now, all of those environmental risk factors like the chronic pancreatitis, obesity, smoking, those alone, in the absence of a genetic mutation or a family history, do not qualify for screening for pancreatic cancer. But people who do have the genetic mutations or have a strong family history, so 2 first-degree family members or 1 first-degree, 1 second-degree family member, or especially 3 first-degree or 3 first and second-degree family members, those all qualify for pancreatic cancer screening. And the way we do that is by every year taking a look at their pancreas using either an endoscopic ultrasound or an MRI based on patient preference as well as local expertise, to just look at the pancreas in very close detail to see if any spots or bumps or changes are occurring, in which case we would biopsy and initiate treatment before things get more advanced. So the last part of sort of the talk here, just to kind of round out, is I think one of the more important parts, and that's how do we deal with some of the complications of pancreatic cancer for our patients. People with pancreatic cancer suffer a lot, okay? They have a lot of complications, both from a psychosocial standpoint to a physiologic standpoint, that really decrease their quality of life and can be very challenging. In addition to dealing with the treatments that are meant to, potentially cure the cancer or decrease the cancer burden, there's a lot of symptoms that are very important that we as practitioners address. And endoscopy has played a central role in doing that. So when we talk about palliation, that means relieving the symptoms, providing comfort. And the main complications that we're going to see are bile duct obstruction, obstruction of the small intestine from the tumor growing into it, pain, which we talked about can be very severe, as well as the malabsorption, diarrhea, and weight loss. So these are things that we always should be looking out for in our pancreas patients and addressing them promptly if there's signs of them. The bile obstruction, like we talked about, occurs when tumors are in the head of the pancreas and they block the bile duct from draining into the intestine. A lot of people, in addition to getting jaundice, will get itching, pruritus, and sometimes this can also set them up for a bad infection in the bile duct because bacteria sort of crawls up that bile tree because of the lack of flow. But jaundice and itching is the most common thing that you'll see. This is just a CT scan, again, showing a tumor in the pancreas, and this bile duct is very extended. It's dilated. It's a tube that, instead of being 6 millimeters is now all inflated because it's blocked. The bile just has nowhere to go. This is on an MRCP or an MRI. It just shows sort of the blockage here. This is the liver up here and all the ducts of the bile ducts in the liver. And you can see this big bile duct kind of coming down. And then right when it gets to the pancreas area, it just stops. And that's because there's tumor right here that's blocking it and causing it to expand. The same thing applies to the pancreas duct. It's all big and swollen, and it just stops abruptly right here before it gets to the intestine. That's because there's a tumor right here. This is on the scope. We can see sort of, we're doing what's called an ERCP, which I'll talk about now. You can see the bile duct getting compressed. You can see how narrow it is right here, and that's because there is a tumor pressing in on it. So this tube all of a sudden just gets blocked before it gets down to the intestine. So what we do for that is something called an ERCP. This is another endoscopic procedure that is meant to access the opening of the bile duct called the ampulla and get a stent in here. So we use our devices to access the bile duct, go around the tumor, and deploy a stent. So when we're going down with the scope, we're seeing the opening to the bile duct on this simulation, similar to a tiny little hole here. And we're using our devices like a wire to get into that opening. And then over that, we're advancing a stent. And that stent, what it does is it sort of pushes away the tumor and just kind of props open that bile duct so that the bile can now flow from the stent or around the stent into the intestine like it's supposed to. And when we talk about stents, there's two different types. There's plastic stents or there's metal stents. Plastic stents have been used for the longest time. They were the first stents that were developed, and they're affordable, they're easy to place, and they're easy to exchange. The metal stents are relatively newer, just in the past, a few decades. And these stents tend to be bigger. They're a flexible type of a metal that is either covered or uncovered. And these tend to have a bigger diameter. And these stents, in general, tend to be favored over plastic stents when we're talking about durability. Plastic stents can get clogged, and they tend to get clogged in about 3 to 6 months. So when we have patients that get plastic stents, we're oftentimes talking about maintaining their stent. We tell them to look out for the signs of a stent being blocked, which is turning jaundice again, or your liver tests go up. And a lot of times we'll have to exchange these stents preemptively every 3 to 6 months. Whereas with metal stents, the patency tends to be longer and sometimes can be up to 12 months. And in general, metal stents tend to be favored as a first-line approach nowadays for patients who are getting biliary drainage, unless they have a life expectancy of just a few months. This is what these stents look like, the metal stents when they're coming out in the intestine. And this is on an X-ray. You can see the bile duct here, and then the stent is in the bile duct, sort of propping it open, and then bile flows through there. So kind of the next sort of blockage that occurs, but can be very devastating, is a blockage of your intestine. You can have the tumor occluding your stomach, and that's because of compression of the first portion and the second portion of your duodenum. And these patients vomit, they can't keep food down, their belly distends, and they can be absolutely miserable. Usually when this develops, it usually means the tumor is quite advanced. And about 20% of patients with pancreatic cancer, will develop this along their course. So how do we fix that? sorry, this is just a picture of a stomach that's all filled and distended with fluid because of an obstruction of the intestine from a pancreatic tumor. So there's two major ways to fix this blockage. One is with surgery. It's called a surgical gastrogenostomy or a bypass, in which case the surgeon essentially just kind of cuts into the stomach and then cuts into the small intestine away from the blockage and just connects the two. So food would come down your esophagus into your stomach, whoops. And instead of going this way, you know, where it would just pass through this new created communication and then just pass down into your intestine. Sometimes this will be done when patients are going under for surgery to get the tumor removed, but a surgeon finds that, you know what, this looks like there is more tumor than we initially accounted for. And instead what they do is they convert the procedure to this bypass. The other approach is what's called endoscopic stenting. And this is where we try and alleviate the obstruction without a surgery, but by deploying a stent, which is very similar sort of process as to what we talked about with the bile duct, but this is a dedicated stent that goes into the intestine, again, over a wire, and the same sort of fundamental. We're deploying something that is going to prop open, push away the blockage, and allow for patency of food. And this is a procedure that's done relatively frequently. The advantages of a stent over surgery are a couple. The first is that while both are very successful, both can be very effective, the stent placement tends to be associated with a much shorter hospitalization time. In fact, a lot of times we're doing these stents as outpatients. Patients don't have to have a surgery, they don't have to be admitted. And so the risks also tend to be much less when we're doing a duodenal stent rather than a surgery. It's more affordable, less hospitalization, and is just as effective in terms of the treatment. So a lot of patients will opt for that. The disadvantage of the stent is that the stent can sometimes slip. They can slip back into the stomach or into the intestine. They can get clogged. So sometimes they need some maintenance. So this is a decision that would be made with your surgeon as to what's the best approach, stent versus doing a surgery if you have a blockage. And then finally, the abdominal pain. Abdominal pain in pancreatic cancer, like we talked about, can be just absolutely debilitating. These patients will require pain medications. Tylenol, ibuprofen seldom are sufficient to cut it. And a lot of times these patients will require opioids or narcotics to reach the level of control. And with those high doses of narcotics, a lot of times they develop problems, constipation, things like that. And so there is an endoscopic approach to improving the pain, and that is by doing what's called the celiac plexus neurolysis. And that's where we use, again, the endoscopic ultrasound. We go down to the stomach, we find these nerve plexuses and directly inject a solution into them to desiccate them, to sort of cut them off. And so we're getting rid of the nerves that are firing from the pancreatic cancer. And this can significantly reduce the risk, the incidence of pain. It can't get the pain down to zero, but when it's effective or it's successful, we can essentially reduce the pain med requirement by sometimes 50 to 75%. This is just an ultrasound picture showing that ganglion and our needle going into it and injecting the solution directly into it. The duration of efficacy for pain control is limited. It does wear off, and the median duration is about 24 weeks. And then last but not least, patients have malnutrition because of a combination of factors. One, the decreased pancreatic enzymes that is present, combined with the fact that they are having significant pain and decreased ability to eat, combined with the anxiety and depression that oftentimes comes hand in hand with this significant diagnosis, as well as the fact that cancers can sometimes be pro-inflammatory and cause weight loss in and of themselves. Patients are very commonly malnourished for a variety of these factors. It's important to recognize that enzyme deficiency and treat that, because there is effective treatment. and that is by using pancreatic enzymes. There are several trade names out there for enzymes that can replace what your body usually makes to help you digest food, and they're taken with food to help you break it down. And so it's important to recognize if you're having some of these symptoms of malnutrition to sort of approach this. So just to kind of summarize there, you know, pancreatic cancer is increasing in incidence and the mortality rate remains high. So despite everything that we've been doing and all the advances we've had in treatment, we still have a long ways to go to improve our numbers with pancreatic cancer. Part of that is trying to identify patients that are highest risk for pancreatic cancer and enrolling them early in screening. Symptoms tend to occur in advanced disease. Always be weary of jaundice and make sure that it gets addressed if it's ever present. There are several genetic and non-genetic risk factors for pancreatic cancer. And if you meet any of that genetic risk factors that we talked about, screening in conjunction with your doctors is a very important discussion to make. And then always be wary of the complications of pancreatic cancer. There are many, and there are ways to help with those so that patients can focus on their quality of life as they're dealing with treatment or with palliation. And so I'll just sort of end there. I hope I didn't go over. I hope that was useful. And let me just pause. Any questions, anything I can answer? That all makes sense.
I have a quick question, Dr. Eklhatib.
Yeah.
For the celiac plexus neurolysis, can that be done more than once, or is that once it's been done and it wears off, it can't be completed again?
Yeah, that's a great question, Nicole. And the answer is yes, it can be done. So if it works the first time, then once it wears off, we can definitely do it again. The second time may not be as pronounced of an effect based on our studies, but it still can give us an effect. The patients that didn't get a response or it didn't help them the first time, then there is no utility in repeating it. You know, and we'll oftentimes work with our oncologists, and a lot of times the pain service is involved as well because of just how severe the pain can be. But it's of utmost importance that pain control is treated. It deserves the same amount of attention as the curative discussions, the surgeries. The pain control is should be at the top of the list. And patients should ask their doctors about the possibility of a celiac plexus neurolysis if they want to decrease the amount of pain meds they're using, or they want to see if they can maybe even not need pain medications at all. So it's something important to discuss. Okay.
Thank you.
Any other questions?
Any other questions? Yeah.
I have a question.
Yeah.
For somebody with a family history of pancreatic cancer, how do you get tested for the genes?
Yeah, that's a great question. I wish I wanted to go into that into much more detail too, because it does warrant almost its own discussion. So the best way to do to detect if you have a genetic predisposition is with the assistance of a geneticist. And so genetic counseling with a certified geneticist is the best way to go about doing it. And the way they do it is they'll sit down with you and they will get a very extensive family history of not just pancreatic cancer, but all cancers on both ends. And they'll form sort of this pedigree, and they'll see if you meet sort of criteria for possibly having a genetic predisposition or a genetic mutation. And if you do, they'll tell you which of these needs to get done, and it's usually done through a blood test if we're talking about detecting a mutation in somebody who doesn't have cancer. The other ways we detect mutations is if a patient does already have pancreatic cancer, and they can do some testing on that actual tumor itself. So for example, someone's father has pancreatic cancer at a young age. They run some genetic testing on that father. They found out that he has a mutation. We then look and see what specific mutation that is, and if it's something that can be inherited to the kin, and then we then talk to the family member, say, hey, there is an inheritable mutation here in this cancer. Can we test for it and how? And the geneticist will go over that. And they're very, 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 very useful, very, very important discussion. And sometimes they'll say, hey, you know what? You don't meet criteria. There's no need for any genetic testing, because there are implications to genetic testing outside of just screening and not screening. There's issues with, health insurance, disability insurance, things like that, that warrant a discussion with a geneticist.
Okay, thank you.
Sure. Yeah, we have a great geneticist, Christina Ruiz and them over at Advocate at Christ. They're actually part of the pancreatic cancer screening sort of protocol that we have set up there, and they're really fantastic. They identify patients that are at risk. They send me a message. I mobilize, get the patient immediately set up for screening with an endoscopic ultrasound or a scan, and then we enroll them and we do direct communication. So it actually works quite well. Any other questions at all? Oops, wait, let me see something. Okay, great, sorry. All right, if that's it, go get some dinner, guys, after seeing that photo of steatorrhea, okay?
Thank you so much, Dr. Eklhatib, and we do appreciate the photo because, sometimes when you just say, fatty, oily stool, not everyone knows what to look for. So sometimes you have to see those pictures to know, because, the more we can be aware and look for these signs and symptoms, hopefully we can, prevent people getting later stage diagnoses and things like that. So
absolutely, for sure. And then again, if anybody ever has any questions, please, share my number, share my contact information. I'm happy to discuss on a personal level. I'm happy to discuss in my office, even if it's just a curbside. Like I said, I built my career around this, so I'm happy to help in any way that I can.
Thank you so much.
Stephanie, you're muted.
Stephanie, I think you're muted.
Thanks, guys. I was just saying thank you again so much. And thanks everyone for joining us. And Nicole and I just want to remind you that we have a gastrointestinal support group the second Thursday of every month. I think next month, just a note, we'll be holding it on a Wednesday, but typically the second Thursday of the month. So if you want to join us, go check us out at gildasclubchicago.org. And it starts at 5:30 on those Thursdays. Yeah. Thanks so much, everyone. Thanks again.
Thanks, guys.
For doing this.
All right. Thank you, Dr. Eklhatib. We really appreciate it.
Thank you.